All right. Hello, everyone. For those of you who don't know me, my name is Megan Hardy. I'm one of the infectious diseases clinical pharmacists at WV Medicine, West Virginia University Hospitals. So today I was going to talk about oral antimicrobial therapy for bone and joint infections. Oops. Sorry about that. Starting with just an overview of bone and joint infections in and of themselves. This is not by any means all encompassing, but just some background information. So significant morbidity or mortality are associated with bone and joint infections, making them challenging to manage due to prolonged treatment durations and penetration of antibiotics into bone. I will be using the terms like bone penetration loosely here. We'll get into kind of why that is and why that's not really always the best term to use here. And bone and joint infections require a well-coordinated multidisciplinary treatment approach for effective management. Some examples of bone and joint infections just being our osteomyelitis, periprosthetic joint infections, septic arthritis, spinal infections like discitis or vertebral osteomyelitis, as well as diabetic foot osteomyelitis. So I want to jump into some of the pharmacokinetics of our oral antimicrobials here and why we can choose to use them in bone and joint infections. But starting with why we don't see very many bone and joint studies. So we do see a lot of studies on like oral antimicrobial therapy, but not a lot of specific studies on bone and joint. And that's because the techniques for bone and joint sample preparation are very inconsistent and haven't been validated. Bone samples, when they are taken, often contain large amounts of blood in excess of the intravascular portion, and bone concentrations of antimicrobial agents may appear artificially high unless excess blood is removed because of that. Bone samples are often homogenized by grinding into a powder or pulp, and I'll talk a little bit about that later here. And so this is the possibility for drugs to absorb into the grinding device as well, or the sand or aluminum oxide used to facilitate the grinding. Once again, not validated. So concentration differences between studies we're going to see a lot of differences in those within those studies, depending on the grinding technique. So it's important for studies to specify drug concentration differences between cortical and cancellous bone as well, since those types of bone are very different from one another. But once again, a lot of these are homogenized. So we have very few studies that actually look at those things separately. Also, bone concentrations are almost exclusively studied in non-infected infected patients. So the effect of disease state on bone penetration is often unknown. Sample sizes are often small for this reason as well. Studies will include different bone conditions that may affect the penetration. So like arthritic or calcified bone, low bone density, and maybe our elderly patients, bone cysts, et cetera, all kinds of things. So just taking a look at how big this difference between the cortical and cancellous bone is, just to kind of highlight what I was talking about earlier. So our cortical are a compact bone, so is made up of the epiphysis, so the thin shell, and the diaphysis, the thicker shaft. The cancellous or the trabecular or spongy bone has about 5 to 70, so quite a variability there. 5 to 70% is the density of cortical bone, with 30 to 90% porosity. So once again, quite a big difference there, as well as a higher proportion of extravascular fluid. So you can see when this bone is homogenized, we don't necessarily get very accurate ideas of this penetration into bone. So looking at some considerations in pharmacokinetic sampling. So the majority of pharmacokinetic analyses in bone penetration studies are done by calculating these concentration ratios between blood and serum. So this will often permit only one sample per patient due to the nature of bone and joint studies, like we talked about before. So for example, joint replacement surgeries. And then we have this phenomenon called system hysteresis. So that shows that the concentration ratios between tissue and serum will change over time unless equilibrium has been reached between the compartments. So it makes these ratios really difficult to interpret based on a single time point. And the ratio depends on the sampling time itself. So we can't really look at this as a snapshot and get an accurate picture of what these bone concentrations really look like. So this is an example over here of what I'm talking about. So plasma concentration ratio for a 2-compartment model after a 24-hour constant rate infusion is what we're looking at here. And concentrations are simulated for a 2-compartment model with linear pharmacokinetics. And this here shows, so C1 over here is the concentration of the central compartment or the plasma, and C2 is the concentration of the bone tissue compartment, or in the bone tissue compartment. and RZ is the bone plasma concentration ratio during the terminal phase. So you can see the variability here as time passes. So next I want to jump into the different drug classes themselves. I'm not going to include everything here, but really the ones that we will most commonly see and use, especially here at WV Medicine. So in looking at how lots of different factors related to pharmacokinetics go into whether or not we can utilize them for our bone and joint. So it's not just about bioavailability. It's not just about, once again, that bone penetration. So I'm going to highlight some studies related to each of these different antibiotics that I'm going to talk about, keeping in mind that the bone studies that these are taken from are all very different from one another. So looking at our penicillins here, so we know that these are time dependent, so time over MIC. They're largely hydrophilic, so they don't necessarily readily diffuse across the membrane, so that's a factor as well. Penicillin itself is about 80% protein bound and about 20%, 25% bioavailable, but we know that we can administer this more frequently and kind of maximize that time over MIC. Amoxicillin is a little bit lower protein bound, so 20% protein bound with a higher bioavailability at about 60%. And augmentin is even a little bit higher still. It's very comparable to amoxicillin. The addition of the clavulanic acid component doesn't really add much to it, but it has about 18% protein binding from a bioavailability standpoint, at least. It's about 75% bioavailable. So our cephalosporins, once again, being beta-lactams, they are time dependent, largely hydrophilic. Highlighting some particular ones here, we do have cephadoxil on here, which we utilize quite a bit, and putting cephalexin in that same bucket as well. Both of those have very low protein binding, or relatively low, 10 to 15%, and they're about 80 to 90% bioavailable. Cephaloxime is not on here, but I did want to highlight that because that is an agent that we will typically use as well. Cephaloxime being 18 to 33% protein bound and about 40 to 60% bioavailable. But once again, pushing the doses on these, I know we typically utilize higher doses in patients with normal renal function with the cephaloxime for more invasive infections like bone and joint. So moving on to our quinolones. So these are what are going to be the most frequently studied in the bone and joint studies that we are familiar with. So I'm not going to talk about, I don't have levofloxacin listed on here, but I, of course, will talk about it. So quinolones in general being concentration dependent, so different from our beta-lactams. These are largely lipophilic, so they do much more readily diffuse across membranes and into tissues and everything like that with potentially lower doses. Ciprofloxacin is about 20 to 40% protein bound and about 70 to 80% bioavailable. Levofloxacin is comparable protein binding wise, about 24 to 38%, but it is almost 100% bioavailable, so about 99%. And then moxifloxacin is 30 to 50% protein bound and about 90% bioavailable. So we see the bioavailability is very high here. Looking specifically at Cipro here, penetration into turbinate bone studied in patients undergoing turbinectomy showed concentrations measured 3 hours after an oral dose of 250 milligrams exceeded the MICs several fold with just that single 250 milligram dose. And we know that we rarely utilize doses even that low with ciprofloxacin too. So that just really demonstrates how high it exceeds the MIC too. So, and then another study looking at sternal bone showed that ciprofloxacin in sternal bone demonstrated mean concentrations of 12.7 plus or minus 6.46 micrograms per ml an hour after a single 750 milligram oral dose. These are older studies, but these are all things that we already kind of know about our quinolones. And then looking at moxifloxacin, this utilized a Monte Carlo simulation for, so this simulated 10,000 patients based on data from 24 patients. So once again, we talked about not having actually, not being able to have a large quantity of samples given the nature of bone and joint infections, joint replacement, things like that. So these patients given 400 milligrams orally 2 to 7 hours prior to a total hip arthroplasty showed median concentrations in both cortical and cancellous bone of 2.5 micrograms per ml, which for reference will exceeds the MIC 90 of Staph aureus of that 0.125 micrograms per ml. Not that we're typically going to use moxifloxacin for like staphylococcal infections, but just to demonstrate how high we can get above these MICs with quinolone. So we have a lot of other agents. I'm not going to go through all of the drug classes individually, but I do want to highlight once again some that we will utilize quite frequently. So starting with doxycycline. So this one is very highly protein bound, 73 to 90% or 95% bioavailable. It is more time dependent, and it is lipophilic. So in this looking at a mandibular bone study, the mean mandibular bone concentration of 4.9 plus or minus 3.8 micrograms per ml 3 hours after administering a single 200 milligram oral dose exceeded the MIC 90 of doxycycline against staphylococcal species. And so once again, we're not typically going to use like a 200 milligram dose. We'll usually use 100, but just to highlight, once again, exceeding that MIC. And then we're going to look at trimethoprim sulfamethoxazole or Bactrim, which is about 70, the sulfamethoxazole component's about 70% protein bound, and the trimethoprim component's about 44% protein bound. But together we have about like 85 to 90% bioavailability, so quite bioavailable. And they both are small lipophilic molecules here. So once again, not necessarily utilizing this dosing, but just to highlight this. So the 3.2 grams of sulfamethoxazole, 640 milligrams of trimethoprim given 2 days preoperatively prior to TKA, reached 4.2 to 9.4 micrograms per ml in all bone types. So, and this just really demonstrated bone serum ratio in cortical bone, cancellous bone, and bone marrow. So it did look at, was able to look at 3 different types of bone, 0.2, 0.3, and 0.3 respectively. So moving on to linezolid, which is another common agent that we will utilize, it's 31% protein bound and about 100% bioavailable. And it is a very small, moderately lipophilic molecule as well. So 600 milligrams twice daily for 2 days prior to total knee arthroplasty demonstrated mean concentrations in cancellous bone synovium and synovial fluid of greater than 4 micrograms per ml, which is more than double the MIC for Staph aureus and strep species as well. And then looking at rifampin, very highly protein bound, but it's about 90% bioavailable and very highly lipophilic, so it will readily diffuse. So 600 milligrams given orally every 24 hours. In total, HIP patients achieved mean bone concentrations of 1 to 3 days later of 1.3 and 6.5 micrograms per ml in cortical and cancellous bone, respectively. Once again, much older studies, but just demonstrating the kind of what we already know about these drugs. So studies indicating excellent penetration into bone tissues at higher MIC breakpoints, or higher than the MIC breakpoints of rifampin against Staph aureus. So aside from kind of highlighting these little blurbs of literature for each individual drug that I wanted to highlight there, let's talk about some actual literature for bone and joint. Of course, starting with the OVIVA trial. So our 2019 kind of landmark trial, oral versus intravenous antibiotics for bone and joint infection, being a randomized controlled non-inferiority trial, looking at definitive treatment failure within 1 month of 1 year of randomization, with 1,054 participants at 26 different UK facilities within 7 days of surgery or 7 days after after antibiotic initiation, if no surgery. They were randomly assigned to receive either IV or oral antimicrobials to complete the first 6 weeks of therapy. Results demonstrated treatment failure of 14.6% in the IV group and 13.2% in the oral group. Intent to treat population demonstrated a difference in risk of treatment failure of negative 1.4%, which was shown to be non-inferior. So the incidence of serious adverse events was not significant between the groups as well. Study concluded, as we know, so oral antibiotics non-inferior to IV antimicrobials when utilized during the first 6 weeks for bone and joint infections. 23.5% of the IV group and 23.3% of the oral group had DARE procedures, which we will also talk about later. But this trial was deliberately inclusive. So it didn't select due to specific organisms, procedures, or site. And I wanted to look specifically at the oral regimens that the OVIVA trial does utilize. Sometimes it gets a little bit cloudy here. So there are 19 different planned oral combinations In the PO arm, the most common was Cipro plus Clinda, which is not one that we're typically going to use, but that was the most common in this particular study. And then the second most was ciprofloxacin plus doxycycline. So there was 17 participants. This also does not account for the adjunct rifampin, which was analyzed separately. So we'll look at that next year. So this table from OVIVO will highlight the actual rifampin use in these patients. So you can see the majority of them in the IV and the PO arm did not utilize rifampin, and those that did utilize rifampin utilized it for greater than 6 weeks. So now we look at the role of rifampin for the treatment of orthopedic implant-related staphylococcal infections. This is an old randomized controlled trial, but I just want to kind of highlight kind of where we came from and some newer studies from here. So this was a randomized placebo-controlled double-blind trial with the primary outcome being clinical cure, which was defined as lack of clinical signs and symptoms of infection, a CRP of less than 5, absence of radiological signs of loosening or infection in the final follow-up visit at 24 months. Treatment failure here was also defined as persistent clinical or laboratory signs of infection, persisting or new isolation of the initial organism. And this study looked at 33 patients, so relatively small sample size with culture-proven staphylococcal infection associated with stable orthopedic implants with short duration of symptoms of less than a year. Randomized to either receive flucloxacillin or vancomycin plus rifampin or placebo, followed by either Cipro plus rifampin or Cipro plus placebo long-term. So the results demonstrated that 18 patients allocated to the Cipro rifampin group and 15 patients of the Cipro placebo group. 24 patients fully completed the trial with a follow-up of 35 and 33 months. Cure rate was 12 out of 12, so 100% in the Cipro rifampin group compared to 7 out of 12 in the Cipro placebo group. So really this study just shows that among patients with stable implants, short duration of infection, and initial debridement, patients were able to tolerate long-term, or inpatients able to tolerate long-term therapy, so 3 to 6 months of therapy with ciprofloxacin. So this also looks kind of at a suppression picture as well, not necessarily that initial treatment. With the addition of rifampin, did experience cure of infection without the removal of the implant. But then we fast forward here to rifampin combination therapy in staphylococcal prosthetic joint infections in 2020, another randomized controlled trial here with the primary outcome being no signs of infection after 2 years of follow-up. And this study was a little bit larger with 99 participants, 65 of which had proven staphylococcal infections. The study enrolled adults with total hip or total knee prosthesis and clinical signs suggesting early or acute prosthetic joint infection after a DARE procedure. And they were randomized to either antimicrobial therapy with or without the addition of rifampin. And the results demonstrated that 48 patients that made it to the final analysis. So there were 23 in the rifampin combination group and 25 in the monotherapy group, and there was no significant difference in treatment success between the two groups at 2 years post-DARE. So 74% rifampin group and 72% monotherapy group. So this study concluded that there was no statistically significant advantage of adding rifampin to standard antibiotic treatment for acute staphylococcal PJIs. And it is important to note here the recruitment was slower on this one than anticipated, so the study did stop before meeting the estimated sample size. So jumping into the actual prosthetic joint infections themselves here, and some studies highlighting specifically this indication. So prosthetic joint infections, or PJIs, being or complicating 0.5 to 2% of primary total hip arthroplasties and total knee arthroplasties. And they represent significant morbidity and economic burden. Prosthetic joint infections following DARE procedures typically managed with IV antibiotics followed by prolonged oral therapy, including oral suppression following the initial treatment duration. Our IDSA guidelines recommend 2 to 6 weeks of IV therapy in combination with rifampin 300 to 450 twice daily, followed by rifampin plus companion oral drug for 3 months for total hip and 6 months for retained implant. So what actually is a DARE procedure? So I've been talking about it quite a bit, but this is our debridement, antibiotics, and implant retention. So it's actually one of our least invasive surgical management strategies for prosthetic joint infections that involves excision of the infected skin margins and sinus tracts if present, radical synovectomy, thorough lavage, and exchange of modular components, so the polyethylene layer. So as opposed to removing hardware completely. And now we have some studies looking particularly at these DARE procedures. So we have duration of antibiotic treatment in prosthetic joint infections. So this is a randomized controlled non-inferiority trial looking at primary outcome of persistent infection within 2 years of the end of antibiotic therapy. This study had 410 participants and enrolled patients with microbiologically confirmed PJI managed with an appropriate surgical procedure. And they were randomly assigned to either 6 weeks or 12 weeks of therapy. So once again, representing that oral suppression period as well. DARE represents 40% of the study population. And of note, the majority in the oral group was treated with fluoroquinolone plus rifampin. And results demonstrated a median duration of IV administration was similar between two groups. So 9 days of IV was the median between both groups. And the difference in risk of persistent infection, 6 versus 12 weeks, was 8.7%. So this did not meet the criteria for non-inferiority. So essentially, the study concluded that a 6-week course of antibiotics was inferior to 12 weeks for DARE. Vast majority treated with indefinite oral suppression here too. So once again, this representing the duration of suppressive therapy. And the last study that I want to look at is the duration of therapy and use of quinolone rifampin-based regimens after debridement and implant retention for periprosthetic joint infections. So this is a single center retrospective cohort, primarily looked at the failure of a DARE procedure. And the methods were, this is a retrospective chart review of 247 cases of prosthetic joint infection after DARE, and included patients meeting criteria for diagnosis of PJI who underwent DARE for the first time at that particular institution. And the results showed that a 5-year cumulative incidence of failure was 28.1%, but there was no association between duration of IV antibiotics, so median of 42 days, and treatment failure. Shorter durations of oral therapy were associated with higher risk of treatment failure, and that was statistically significant. For staphylococcal knee prosthetic joint infection, use and prolonged duration of rifampin was associated with lower risk of failure. So looking specifically at that staphylococcal prosthetic knee, no association was found between fluoroquinolone use and failure, however. So the duration of the initial IV antibiotics did not correlate with treatment failure. And rifampin in this particular patient population was recommended for this study for staphylococcal knee PJI specifically, and there was also found to be no benefit of fluoroquinolones in staphylococcal PJI, which makes sense when we think about kind of how we utilize fluoroquinolones for treatment or targeted therapy. So this is from that same study. So I just thought that these were kind of cool to include. So estimated relationship between oral antibiotic duration and failure among PJI cases free of failure 60 days after DARE. So this just shows that there was this initial increased hazard ratio, which makes sense because it's within this that very early in the first year. So increased hazard ratio appeared to be driven by data early in treatment course. So really the first 90 days versus after that 1-year mark. However, there was no detectable differences in risk observed over longer durations. So comparison of 5-year versus 1-year durations, for example. So that remains pretty stable, but you can kind of see where after that 1-year mark is kind of where we see that the hazard ratio, starts to increase some more, but it's not necessarily, it's largely stable after that point. And then lastly here, another figure is just the estimated relationships between IV antibiotic therapy and failure, which I also thought was interesting here. So this essentially shows that really looking at the 4 and the 6 week mark down here, that there's really no difference in hazard at the 4-week mark versus the 6-week mark. So I know that this is always something that kind of pops up for us when we talk about durations of suppressive therapy and things like that. So I think that these studies are just important to highlight so we can see kind of what data is there and help us make that decision. And so really some key takeaways here. So select oral antibiotics, as we know, will have sufficient bone penetration. Once again, knowing what that bone penetration really encompasses as far as pharmacokinetics, time versus concentration over MIC, lipophilicity, bioavailability, to adequately treat bone and joint infections. However, the optimal duration of oral suppressive therapy and or rifampin use remains unknown in patients with implant retention. But we did see in a couple of studies here that shorter durations of oral therapy were associated with higher risk of treatment failure in the 2 studies that we looked at here, at least. And then lastly, the addition of rifampin may be beneficial in patients with PJI and implant retention caused by staphylococcal species specifically. This always being, once again, a risk-benefit discussion. And as an ID pharmacist, we are always happy to help assist with that decision as far as like drug interactions, monitoring, etc. And with that, I think that's all I have. And I'm happy to take any questions.